the concept actually is changing, and epilepsy is probably right now regarded as a network disease. And it's modification of the network. And even if it is resection or ablation, and even a generalized epilepsy, it's not one size fits all or one procedure fits all. And even each procedure can be personalized to the individual epilepsy we're talking about. So I'll take you a little bit through this. And the first thing is actually this very important paper, actually from Helmstetter, who is an eminent neuropsychologist. Why do we bother trying to develop new epilepsy surgeries, etc.? What this shows is 3 procedures. The classical, at the top, classical anterior temporal lobectomy, where you take out the region, and this is the most common epilepsy that's surgically amenable, temporal lobe epilepsy. And you can see, if you look at learning and memory, what happens is both your learning and your memory, if you look at the controls, goes down. So there is a price to pay. You become seizure-free, but your learning and your memory might suffer from this. If you just have only a lesion laterally, like here, you can do what's called a lateral lesionectomy, leave the mesial parts alone, and you won't have any deficit, neither in learning nor in memory, compared to healthy controls. If, and that was our hope in the past, if you just take this out selectively, the parts close to the midline, you still will have a memory deficit. So we were looking and refining procedures and looking for new technologies that would allow us to render the patient seizure-free without this price, either the learning or the memory or both. And we know that the memory deficit, even in these selective procedures, come from the approach. When we come from laterally, when we disconnect this area, that leads to a memory deficit. So we were looking for new ideas and new technologies to do this. The classic EEG, even if you do this, the high resolution, and by the way, this is actually the head of an eminent scientist, Wolf Singer, who is a Max Planck director, can be very misleading, because what you record from the surface of the head is just a projection of the epilepsy that can be very deep inside in the brain. So this is before we make any assumptions or plan any epilepsy surgery. We, in the vast majority of cases, do what's called a stereo EEG. That was a technique developed in France, actually, where we put tiny electrodes with precision of 0.5 millimeters in a lot of brain areas to find out and record from there where the actual seizures come from, which will allow us to tailor where we either ablate, resect, or modulate the brain function. And it's very important because you can't see epilepsy on the MRI scan. Just doing it on anatomy base is not really a rational approach, because we're treating the physiology, we are treating the epilepsy, not the anatomy. If you then do this, you can actually find a way to avoid the memory deficits by not coming from the side and not disconnecting the hippocampus, the mesial parts, but by coming from behind. It's the long way, sort of counterintuitive, but it's the safest way. And what we have done now, and we've now done more than 300 laser fibers, is treat temporal epilepsy, predominantly in mesial temporal epilepsy, and other areas of the brain as well, to use lasers. And this allows you to monitor the temperature on A, to look at the lesion that develops whilst continuously scanning the MRI, which is B. And this is based on what we've done before, where we put multiple electrodes in this area and figured out where exactly comes the seizure from. And only that area is ablated. And you can see that our model from the MRI temperature measurements, which is then verified by a scan 60 seconds after the ablation, is super precise. We can predict exactly where we lesion with a precision of, again, 0.5 millimeters. The important thing is, and that has been shown by other groups, but ours as well, is if you then look at the brain right next to it, a millimeter basically, it's totally intact, which is very important because that's what we want. We want to get the patient seizure free, but not damage any surrounding functional brain. So we've perfected that, and now pretty much it's a standard routine. We've done one today. We'll do one literally every week and get our patients from a lot of other states than Illinois. And this just shows you the ablation confirmation again in another scan. So this is the first 171 patients where we have long-term outcome data. Anybody who tells you his data like 6 months after surgery, that's quite interesting, but fairly useless because it's the long-term outcome data. After 1 year, you can really make a prognostic statement whether the patient will remain seizure-free or not. So for mesial temporal sclerosis, it's our first-line treatment. We don't do any open resections for that anymore. Rare disease, hypothalamic hamartomas, which reminds me, Aisha, that this is actually an interesting topic for rare epilepsies.
Oh, good.
It's, again, our first-line treatment because there it's actually 95% seizure freedom. For mesial temporal lobe epilepsy without hippocampal sclerosis, it's an alternative to temporal lobectomy, the classic procedure. And actually, it's our first-line treatment now, and I'll show you why in a second. For drop attacks, we use the laser to do callosotomies to stop the drop attacks, and I'll show you our long-term data. For cortical dysplasias, again, we don't have huge, because it's so rare, huge numbers, but we've done about 20 patients so far, and the vast majority is also seizure-free, but we don't have 3-year outcome data. So what's the actual efficacy? So if you have mesial temporal sclerosis, the laser ablation, in 78%, you become seizure-free. And if you have mesial temporal lobe epilepsy without hippocampal sclerosis, you still have a 53% chance of becoming seizure-free. In hypothalamic hamartomas, it's actually better now, but our data was 89%. And in drop attacks, 85% reduction after callosotomy. The important thing, coming back to the first slide I showed you, is, and I'll show you the data, if you look at the whole literature, people reported visual field defects, but no cognitive declines. That means no memory and no learning deficits with this approach. And that is, of course, a major breakthrough. The outcome data you can get with open surgery as well, but you will have to pay this price. So if we look, and I'll show you the data in a bit more detail, because that's really the fascinating part, in all of our analysis, there were no significant effects pre and post laser ablation. So one of the most important things is the verbal memory. That's important if you have a nice, interesting profession or even academic job. You don't want to lose that ability, of course. And you can see, except for one patient here, and that was because the patient couldn't read, which had nothing to do with the epilepsy. He was just blind. There was no real change in visual memory. And the reason why this is good pre and post is he was actually reading, that's a mistake, reading in Braille, and then they tried to do a visual test, so the psychologist didn't know that. So the same is with delayed visual memory. Again, no real change. And most important, also executive functioning. So your executive function doesn't suffer. And these are the areas where you see massive changes, even after the most refined selective amygdala hippocampectomies. So this is what we want. We want a completely tailored ablation of the epilepsy zone has a diameter of 1.6 millimeters. So it's very tiny. It can be positioned with a precision of 0.5 millimeters. And the whole procedure is done whilst continuously scanning in the MRI. So that adds another safety component. And again, you can very nicely predict from the calculated damage zone, from the temperature map, where the actual ablation will take place. What we found out then, and that was just published online, it will come out next month on the cover of the Journal of Neurosurgery, is if we look at the exact volumes and the disconnections within the hippocampus that we ablate with laser, and then look which patients become seizure-free and which have only reduction in seizures, it is very clear that the so-called entorhinal cortex, which is just underneath, which is the whole outflow of the activity of this area, that needs to be covered. And that's what we're doing right now, since we've looked at those early data, that our laser fiber always covers that. And the last 10 cases after we've implemented that have all become seizure-free. And actually the group in Miami has shown this similarly. So what about other epilepsies? As you can see here, this is a cortical dysplasia. We put the laser fiber in. This is the actual lesion. And you can completely cover this. This is the actual damage zone. This is the temperature. And then you can pull the fiber in the trajectory back, make another test heating, where we only use 30% of the energy, so no tissue damage, and then you can completely ablate this. So we know if you completely ablate it or take it out, your chance of seizure freedom is 80% plus. The other thing that we routinely do is use a lot of functional imaging, and this is what's called a DTI imaging, called diffusion tensor imaging, where you selectively color code the fibers. And the fiber tracks are important. If you hit or accidentally damage the fiber tracks, you'll have a side effect. And we do this in each and every case for the optic radiation, so your visual pathway, because it is very, very close, just above the temporo-mesial structures. And if you have an error of 5 millimeters or more, you can hit that, and the result will be a visual field deficit for the patient. So that's for the nice focal epilepsies, which everybody likes to do, which now we have a perfect paradigm with long-term outcome data by using the laser ablation. But a lot of patients have generalized epilepsy or even mixed generalized epilepsy with different seizure types. Lennox-Gastaut syndrome is a typical. And the most debilitating thing in this context is not the seizure itself, but the drop attacks, which lead to injury of the patient. And we, since 30 years, have done callosotomies where we split the connection between the right and the left hemisphere in the anterior two-third of this connection. And we know this is very effective in stopping the drop attacks, or at least reducing it by 80 to 90%. The problem is it is very major open surgery. There are two very critical arteries running atop this anatomical structure. And there are significant side effects, infection risk, etc. So the structure, the configuration of the corpus callosum, that's the structure, lends itself to put laser fibers in and do this minimally invasively. And this is what you can see here. The movie is running down there. So we put one laser fiber in from the back and one from the top, because it curves in the front of the brain. And what you can then see and get is, this is again a diffusion image. We completely disconnect this part of the brain. And this just shows you the image post-callosotomy, you can see this part where you now see contrast enhancement white, and this part called the knee of the corpus callosum are ablated. And then we did volumetry. This is the normal corpus callosum, and looked how much did we ablate, which is down here under F. And we also looked at the seizure frequency before and right after the callosotomy. And what you can see is this is the frequency. A is before and B is after callosotomy. And these patients have multiple seizures per day, of course. And there's the EEG as well. And you can see immediately after that, the seizures are dramatically reduced already, which has to do with the fact that we probably induce, by disconnecting the hemispheres, induce a network change very rapidly. So this is what we actually do. We connect the 2/3, which is the blue, of the corpus callosum. And that's necessary to do it to that degree, because otherwise you won't have a significant effect. And this just shows you again the length of the corpus callosum that we ablated. And these are the results. You can see the drop attack reduction is really dramatic. In quite a number of patients, we had 100% reduction, 0 drop attacks. And in most of them, it was 80%, even over 50%. But even over 50% has a huge impact on the quality of life of these patients. So coming from the nice focal epilepsy to the corpus callosotomy, which still is, although it's a large area, a focal approach, what about the patients where we can't do a focal ablation or a resection? And that brings us to real network modification. And this is an electrophysiological network, so it's natural to use electrical stimulation to modify this. And this has been done since quite some time. And this is the outcome data, long-term outcome data about deep brain stimulation, where a deep nucleus in the thalamus, deep in the brain of the basal ganglia, is stimulated continuously. And the interesting thing is, these are patients that couldn't have surgery and had generalized epilepsy. You can see if you look from 1 year, 2 years, 3 years, up to 5 years post the deep brain stimulation, the seizure rate drops. So it's a significant progressive effect on the epilepsy. Only about 7% of patients become seizure-free, but there's a significant reduction in seizures, and it gets better every year, which is the proof that you're really modulating the network. And if you look at the seizure severity, now when the bars go up, it's actually less severe, it's better, it's an improvement. You can see the same thing. The seizures not only are reduced in number, but they become less severe, and it gets better every year. And on the right, you see the quality of life, which also improves every year. This is a bit of complicated surgery, not for somebody who just does only epilepsy surgery. If you do movement disorder surgery, Parkinson's, tremor, etc., we operate in this area all the time. So this is a very small area of the brain that you have to precisely hit. And underneath where this arrow points to is what's called the mammillothalamic tract. And that is very important for some vegetative functions, and you don't want to disturb that. So you have to be very precise. So it's not for the faint-hearted, but if you have intraop imaging and you are an experienced stereotactic neurosurgeon, that's a very effective treatment. And this paper shows how and why it works, because this study was done in 2015 and just reported on the clinical outcome data. Which network and why and how it was modified was published in this paper in Brain in 2018. what you can see is if you look at stimulation A and T, that's the area where the electrode is, versus stimulation in other areas where they also put electrodes. You can see only if you stimulate here can you silence the electrophysiological activity and disrupt the network. That was the mechanism. And they also looked at this, the connectivity with MRI techniques, which shows you how closely, how densely connected the epileptogenic networks were. And you can see off and on. As soon as you turn the stimulation on, the connection goes down. And if you turn it off, it goes back to baseline and it goes down again if you turn it on. So this is a very elegant electrophysiological technique to disconnect the epileptogenic areas of the brain, and by that stop or reduce the seizures. Even better is this technique, which has become available not for deep brain stimulation yet, although as part of a trial it is. This is the RNS, which stands for responsive neurostimulation. And that means that we implant electrodes in the central median nucleus, which is a different part of the brain. And we connect it to an impulse generator, which also has a chip in there and allows to record the EEG. And we can wirelessly get the data off, and then we can program this EEG detector to start stimulation only when there's a seizure. So you don't stimulate all the time, but you stimulate when we have a predefined parameter where the system recognizes now a seizure is starting to build up, and then it stops the seizure. And we've been doing this in the basal ganglia. There are 4 patients from MGH, and we've done 3 patients now. So that's 7, which actually have been studied extensively. And what you can see is L is for left, R is for right. You can see at month 0, before we stimulated, this is the frequency where the seizures were detected. And after 7 months, that disappears. And that's the normal spectrum, and both on the right and the left side. So, and this shows where the electrodes are implanted. Again, you have to very precisely position these electrodes, but then you can actually have a closed loop system which allows you to detect the seizure, turn the system on when the seizure starts, stop the seizure, and then turn itself off again. And this is currently only FDA approved for adults, but we're doing a trial. We started that, the response trial, and we will use this now in adolescents age 12 to 17 with simple partial, complex partial, and secondary generalized seizures. So even if you have 2 epileptogenic regions, which is usually a no-go for epilepsy surgery, this does not pertain to this trial. You can have the implantation, and you can get the RNS treatment as part of this trial at the University of Chicago. Which brings us to the worst type of seizures, which is idiopathic generalized seizures, no focus, the whole brain basically creates these seizures. And we've just got FDA approval for that study as well. It's not clinical routine, but we can offer this treatment again in adolescents, starting at age 12 up to age 65. And we just implant stereotactically, as I've shown you before, in the central median nucleus of the thalamus. And the best news of that is, but don't bombard us with phone calls, is the sponsor actually pays for the treatment. So the usual trouble we sometimes have with insurance companies is immaterial here. So it's all paid for. And we still have ongoing, as the only center in Chicago at the University, the SLATE trial, which stands for stereotactic laser ablation and temporal lobe epilepsy, which we still recruit patients for, which performs the procedures I've shown in the beginning, the personalized individual laser ablation of temporal foci based on stereo EEG. So that's what we currently offer. That's our clinical research portfolio, etc. But we're just studying a new system. We now have a laser that's even more precise and allows us to incorporate into the planning the functional imaging. What you see here is, this white stuff. That's the motor tract. That's your motor fibers. And this is where we wanted to ablate. And we can now incorporate this and make absolutely sure that we don't hit the motor fibers. The laser is run via a robot, so we can control it from outside whilst we scan. And it has this wonderful side fire probe, so we can direct the laser in any direction in three-dimensional space where we want it. Give an example, we can direct it away from these fibers, but still cover the rest very effectively, which offers new treatment options, particularly in areas which are very close to the speech center or other very important areas, which in the past the standard lasers were not appropriate for. Finally, then, and this pertains to children, where we perform what's called functional hemispherectomies, which are big open surgeries. And because this whole part, this hemisphere of the brain causes seizures, you need to completely disconnect it from the rest in order to stop the seizures. And these patients have 30, 40 seizures per day. So it's a heroic procedure, but it's very effective, 80% seizure freedom. And we've now again used a different approach. Instead of big open surgery, the first case worldwide was done by Boston Children's. We did the second case in the world literature. We implanted 5 laser fibers and looked at each tract and did what's called tractography. These little orange things, this is the motor tract of that patient, which we specifically wanted to disconnect in this particular case. And this was done in February. And I'd like you to bear in mind, this is what we wanted to do. And this is actually the procedure where you see the temperature monitoring on the left and the actual ablation on the right side. And the important thing is, if you remember, the fibers were very tight together in the middle, widespread at the bottom and at the more upper part. So this is at the bottom where we have widespread fibers, and you need to cover all these fibers to get a complete disconnection. So that's where we used the laser and created this lesion. And then you can, by using different energies, different times, reposition the laser within the fiber. And we did a second ablation where the fibers are very tight together, and you don't want to lesion anything else but the fibers, but those completely. We did this very, very tight ablation, and then we pulled the laser fiber back, and you see we did the upper part, which again, the fibers were more spread apart, and we did a bigger lesion. So you can very nicely individualize and target this and perform procedures that were big open surgeries with a considerable complication rate of 10 to 15%. And this patient now is seizure-free since 9 months and had only 5 stab incisions and small twist rolls. The other thing that we do is, not only do we put these electrodes in to figure out where exactly the seizures come from, but we reconstruct from this EEG in a 3-dimensional space the epileptogenic zone. And sometimes it is like this on the right. It's a huge area, pretty widespread, involves different parts of the brain. This would be very complicated to do a laser ablation on, and here we performed an open resection. But the resection is completely guided by our EEG findings. We don't want to do this based on anatomy, because we're treating epilepsy and not just remove parts of the brain where we know the epilepsy is generated, but we want to tailor it and fine-tune it. And this shows what happens if you have within your resection here in A all your epileptic activity in 3D space, your chances of becoming seizure-free are very, very high, in the range of 85 to 90%. If your resection misses that, then of course your chances are much, much lower. And this is a patient we operated just last week, which shows you that this concept is important even if you have a clear culprit on the MRI imaging. Like you can see here, this small tumor in the temporal area on the surface. Young child looked benign. In the past, you would say, okay, we'll take this out. The surface EEG pointed to this as the source of the epilepsy, and then you have a good 65, 70% seizure freedom. We did way more, as you can see here. This is a post-op image. We took a lot more brain out. So, and the reason is this. This is this called EEG Source Localization, which shows two things. Number one, here's the reason why we did this. Look at the green area. The actual area that generated seizures is much, much larger than the actual tumor, which is known in the literature, because if this tumor, which was sitting there for years, produces seizures all the time, the surrounding brain starts to generate seizures on its own. It's called kindling. And that's very important. The second thing is what you see here on the left is the train. The seizures were generated here, but then left and went up. And this is the upper parts of the temporal lobe. So in order to stop this train, you also need to go and resect all of this. That was the logic why we did a larger resection. And again, coming back, this is based on this, based on the actual three-dimensional reconstruction of the electrical source of the seizures. So that's in a nutshell what we do right now. You see we have different techniques. We still do a lot of open resections in large areas, but we have these innovative trials for which patients can be accrued. And the SLATE trial up and running. The RESPONSE trial is for adolescents. And the IDURANCE trial is for idiopathic generalized epilepsy, children and adults, for which in the past no surgical treatment was offered. Deep brain stimulation was offered partly, but deep brain stimulation is very effective in temporal lobe epilepsy, not so much in other epilepsy, whereas this is a different target, the central median nucleus, for which we have good empirical data that it literally works in all types of idiopathic generalized epilepsy. So that's our motto. I think we should leave this concept of we resect something, we can take something out, or we can't, and that's epilepsy surgery, yes or no, is no longer valid. We can modify networks, we can trim trees, we can do all these things, as Zinkernagel, a brilliant Nobel laureate, said. So the bad woodcutters approach, you fell the tree or left the standing, I think that's out, that's historical. We can do way more things to modify brain function, to modulate epileptic networks, and to intervene either electrically or by doing very smart, targeted, personalized laser ablations or resections. Thank you.
Thank you, Dr. Warnke. That's awesome. And I think for those of you who were who are at the conference or were watching, I think a theme that I am hearing over and over again is the concept of changing networks. And I think that's something new that I haven't really heard in the space of epilepsy surgery. So it sounds very positive and very uplifting. And like what you just said is that the concept of resecting and just being one and done is kind of no longer, like there are so many more options for people. So I think that's really exciting. It's an exciting time.
Yeah, I think it's
yeah,
it's going to be a major change in how we do surgery. Yeah.
Yeah. Yeah. And I'm really, I mean, I know you're in the middle of this RESPONSE trial, but I'm really excited to see where that goes. I think that's going to be a game changer for a lot of young people for sure.
Yeah, I hope so.
Yeah. Anyone have questions on the call? You can unmute yourself. Feel free to chime in.
I have a question.
Please.
Yes. So all of this is very exciting. Learning more about this precision surgery with the laser sounds awesome. My question is, for patients who have a medication that helps to control their seizures and maybe only have 1 or 2 breakout seizures, one, can they elect to have a surgery? Or if they're on medications that cause other issues that are, just not good for their health, are they then candidates for the surgery? Because I only hear a lot about if they failed to more medications.
Yeah. So, I mean, that's the definition of the International League Against Epilepsy is you have to have failed 2 medications, which had to be given for a considerable amount of time, and you have to check serum levels that you really got the right dose. But what you're asking is patients with rare seizures, let's say 1 or 2 a month, where they're absolutely candidates for epilepsy surgery, because even if you have only 1 or 2 seizures a month, you can't drive, your quality of life is clearly impaired. So that is clearly an indication if you have a surgically amenable epilepsy. The second one is actually quite important. A lot of patients are almost seizure-free on medication, but have a lot of side effects of the medication. And not the least one, which we know since 50 years, is if you take a lot of these anticonvulsive drugs for decades, you will get liver damage, no doubt about it. And if you can get off your drugs by epilepsy surgery, that in itself, to preserve your liver function, is already a good reason. Yeah.
Thank you. That's one of the questions a client has.
Yeah.
And one last question, because when you talk about removing that part of the brain, does the brain heal itself after that section of the brain has been removed? Does the brain then repair itself, or?
Well, that is totally age dependent. In a very young child, I would say the term repair is not appropriate. It's not that this part of the brain grows back or anything. What's the term would be neuroplasticity, so that other parts of the brain take over the function that you lose. But that's very age dependent. This is exactly the reason why in these very young children, I showed you the hemispherectomy, where we basically disconnect a whole hemisphere that is dysfunctional and only causes seizures. These patients don't have a palsy on the other side. They can compensate because the brain, this hemisphere, was so dysfunctional for a longer time, for years usually, that their function moved over to the other side of the brain. So that's the most extreme example of neuroplasticity. In older patients, 30 above, etc., that plasticity is not as profound as in younger children, but still, as we can see from the modulation trials, is you get better and better if we modify your network. But exactly, if you have very eloquent areas, then modulation is much better than resection, because if you just use deep brain stimulation or RNS, you're not doing anything to the brain. You're not structurally changing anything. You just modify the function.
Thank you.
I think we had one more question. Someone had a hand raised. The question came through, post-surgery, how long does one's recovery and memory take to return to baseline? Well, I guess you kind of answer that depending on the age and the brain, the quality of the brain.
Yeah, and very much the recovery, that's a very good question. So if you, let's say, have a laser ablation, your recovery is because you don't have a big scar. You have literally no incision. We just stab this through the skin. Patients go home the next day. And if you have an open surgery, that of course takes a couple of days. Your memory function, if you have a laser ablation, you shouldn't have a memory dysfunction. For open surgery, your memory will not, if you have a memory deficit, will not go back to baseline. So that is the sad truth, but there's no way to say it any other way. You will have a, maybe not very profound, but you will have a noticeable memory deficit. But for these newer procedures, laser ablation, neuromodulation, you will have no deficit anyway, because we're not doing anything structurally. For laser ablations, it's very fast recovery within a couple of days.
I actually had the laser ablation surgery by Dr. Warnke in February, so I was just here to kind of listen and just out of my own curiosity. So I would just wanted to say that it was early February 2020, and I have been seizure free ever since. So that was just really, like I said, for my curiosity, and my meds have been lowered since then and will continue to go down. So I just wanted to say that was very successful for me.
That is great news.
Mm-hmm.
That's really great news. Thanks for sharing that.
Yeah, no problem. Thank you.
Are you local to Chicago, or did you travel from out of town?
Yeah, no, I'm local. I just live in Naperville now.
Oh, that's great.
Yeah.
That's great.
Yeah, I met him I was set up with Dr. Tao to Dr. Warnke.
Yeah.
Mm-hmm.
Wonderful. Congrats.
Thank you.
I see a hand. Yeah, go ahead, please.
Hi, I have a quick question, Dr. Warnke. So my son is 2.5 years old, was recently diagnosed. He actually works with the ketogenic diet through the University of Chicago with Dr. Fitsanawang and Andre. And we have done the ketogenic diet to try to lower the amount of seizures. He was born with a malformation of the brain. Mm-hmm. My question is, have you worked on infants of this age with a particular malformation of the brain with success rates?
Yes, so I mean, I would need to see exactly what that is, and I would need to see the images. But yes, we operate on 5-6-month-old patients in that age group, predominantly with malformations. But it depends a bit on what type of malformation that is. If it's a cortical dysplasia or overall malformation, or sometimes it's
an overall malformation. It's
okay.
It's a pachygyria, polymicrogyria.
Yeah. Okay. Yeah. So that really then depends. Then I would need to see the EEG, whether this is generalized or whether there are focal areas, and see if there's any way we can modulate the network. Now, what we can't do is, for example, the RNS trial, because he's just too young for that. But there are other options. And what I haven't talked about is a very old way of modulation, which is vagal nerve stimulation, which is not really happening in the brain, but we put a spiral electrode around the vagal nerve in the neck. So that is an option, and that can be done even at that age. But if you want us to just, we can discuss his case at the epilepsy conference. This is a good thing at the University of Chicago. We're the comprehensive epilepsy center. We are not split into adults and pediatric. So all 20 epileptologists come together with the neurosurgeons and the psychologists. So if you want us to, let Dr. Fitsanawang know, and we'll put him on the agenda.
Okay, yes. Okay, I'll let him know, because I do have a virtual chat with him on December 8th. Also, what with the RNS, that would be open open surgery, correct?
No, no. This would be, well, it depends. The RNS allows to put electrodes deep in the brain, which are also 1.2 millimeters, tiny, through some bone openings. And the actual system is only implanted in the bone, not in the brain.
Oh, okay.
So it would not be open surgery and no resection.
I understand. I understand. Okay. And I could just bring this up at our next meeting. I could just talk to Dr. Fitsanawang, who would then reach out to your team. Is that correct?
Yeah. We
Okay.
meet every Wednesday. I see him once a week. Yes.
Wonderful. Okay. Thank you so much.
My pleasure.
That's great. Lots of really good information tonight. Any other comments, questions? Great.
Okay.
Well, thank you all. Have a wonderful evening.
Thank
Have
you.
a wonderful Thanksgiving. Take care.
Yeah. Thanks.
You as well. Good night.
Good night.
Yeah.